participated in every one of the hearings that the Joint Committee held around the state and has a long history of involvement with this issue. I think the reality is you're deeply committed to this issue, and so we appreciate that. I may actually myself need to leave to go cast some votes very briefly, in which case I will hand the gavel over to my colleague. This is a hearing on, and I want to underline this, the subject matter portion of AB 1800, not the bill itself. This is not a policy committee that has the ability to vote up or down on any bill, but we do have hearings and make findings and recommendations on policy. And so this is a discussion of the policy questions involved that have been raised by AB 1800. The hearing reflects the Senate's commitment to increasing the attention that we focus on the mental health system this year, a system that has received too little attention and too little funding in the past. It's been a remarkable year in terms of the beginning of focusing increasingly on what we have not achieved in the area of mental health services, and this year beginning to fulfill some of the promises of the past that have never been fulfilled to provide adequate mental health services. The Senate requested an additional $300 million in the budget for mental health services. Ultimately, that increase ended up being in the neighborhood of $150 million, which was a sizable increase, but I think we all know only a down payment. We have much, much more to do. A number of issues and concerns have been raised in the debate about changes to the LPS system. These are very sensitive and significant issues, and change should not be entered in too quickly or too lightly. The Senate has contracted with the RAND Corporation to conduct a study on involuntary commitment, and we'll be hearing an update on the status of that study today as part of this hearing. Senator Burton has also indicated that he is very interested personally and on behalf of the Senate and committed to crafting a compromise next year on the issues that have been raised by AB 1800. And it's very much at his encouragement that we are here to have this discussion. This hearing will help us focus on the issues around which a consensus on needed changes in the mental health system can be reached. We will hear testimony from opposing views of the subject matter. Then we'll hear an update on the RAND research project, followed by a panel discussion on future considerations. Then there will be an opportunity for public testimony. There is a sign-up sheet available, which those of you who would like to testify under public testimony, we'd very much like you to sometime during the hearing make your way up here and sign up so we can call your name. It's my intent that this hearing go no longer than 2:30 p.m. because I have an obligation in my district, and it's a 3-hour drive, actually close to a 4-hour drive from here. So I'm going to need to depart the building at 2:30 or as soon thereafter as I can. So when it comes to both the panelists and the public testimony, we're going to have to ask you to be as brief and to the point as you possibly can. Many of you participated in the Joint Committee hearings around the state and did a great job. We want to encourage that kind of get in and get out, make your point kind of presentation, because I think that you're both the most effective when you do that, and it also helps us stay on schedule. So the first panel is made up of representatives of various organizations that have been in opposition to the policy content of AB 1800, and I'd like to ask them to come forward. On the agenda, we have Maria Marr of the California Network of Mental Health Clients, Michele Magar, Protection and Advocacy, John Nickens, Clinical Director for the Progress Foundation, and Ron Schraber, Associate Author of the Wellbeing Project. I'd like to ask you to each come up and take a seat. For the, is it 3 or 4 speakers that we have here? We have all 4? Okay, for the 4 of you, we have about 45 minutes, and so I would encourage you to either wherever you'd like. There's no protocol here. I'd like to urge you to try to each be in the neighborhood of 10 minutes or so, and that would also leave some time at the end of the panel for members to ask you questions. Okay. So do you have an order you'd prefer, or should we go in the order I announced?
Well, can I beg to introduce everyone?
Sure.
Okay.
I'll turn it over to you if you'd like.
Okay, just briefly, I'd like to introduce Michele Magar, who is with Protection and Advocacy Incorporated, a federally mandated civil rights organization for people with mental disabilities. We have Ron Schraber, associate author of respected research, The Wellbeing Project, contracted by the Department of Mental Health, board member of California Association of Mental Health Patients' Rights Advocates, CAMFRA, and member of California Network of Mental Health Clients. And we also have John Nickens. Dr. John Nickens is the Director of Clinical Services for Progress Foundation, a nonprofit agency that provides mental health treatment and rehabilitation to individuals using publicly funded services in San Francisco and Napa counties. He has also served as the chair of the California Mental Health Planning Council, the president of the board of the San Francisco Patients' Rights Advocacy Service, and as a member of San Francisco Mayor's Blue Ribbon Committee on Healthcare. He is here today speaking on behalf of member agencies of CASRA, California Association of Social Rehabilitation Agencies. Michele.
Thanks, Maria. Good afternoon. My name is Michele Magar. I'm an attorney with Protection and Advocacy, a nonprofit agency that is charged under federal and state law to protect the rights of Californians with disabilities. I'd like to go through some of the legal problems of AB 1800, mention some of its policy implications, and suggest some ideas for achieving real mental health reform. But before I begin, I'd like to make some brief introductory remarks. AB 1800 does not do what it purports to do. It does not fix the very real access problems in California's mental health system. It does not address the needs of our homeless population, and it will not target assistance to those most in need. What it will do is take our state backwards by resurrecting failed approaches to mental health care, by stigmatizing the very people it means to help, and by driving people who need help underground. In fact, this bill is so problematic that it has earned nearly universal condemnation from every part of the mainstream mental health community, not only mental health consumers and advocates, but also mental health providers and government officials who run California's mental health system. Organizations opposed to AB 1800 include the California Mental Health Directors Association, the California Association of Social Rehabilitation Agencies, the California Psychological Association, the California Network of Mental Health Clients, and the two major advocacy organizations that represent people with psychiatric disabilities, Protection and Advocacy, and the California Association of Mental Health Patient Rights Advocates. Today I'd like to focus on three aspects of AB 1800. Its relaxed criteria for involuntary commitment, its outpatient treatment program, and the due process protections this bill strips away. Current law allows involuntary commitment if, due to a mental disorder, a person is a danger to self or others or is gravely disabled. Grave disability is defined as an inability to provide food, clothing, or shelter. AB 1800 would expand the definition of grave disability to include persons who present an acute risk of physical or psychiatric harm in the absence of treatment. This proposed standard is based on prediction, on what might happen, and that makes it unconstitutional. In 1975, in a landmark decision called O'Connor versus Donaldson, the Supreme Court made clear that present or imminent danger to self or others is the only justification for imposing the massive curtailment of liberty that occurs when the state forces a person into a mental institution. One reason for the Supreme Court's decision is that courts are supposed to provide a check on the judgment of mental health professionals. A judge can examine whether sufficient evidence exists to support the judgment that a person is currently or imminently dangerous by weighing evidence about the person's current behavior. Evidence of behavior that might occur is not objective, and a judge will disregard it. In fact, even mental health professionals can't predict behavior reliably. These same problems of non-objective and unenforceable standards persist in AB 1800's outpatient commitment provisions. That part of the bill requires that hearing officers order people to follow a specific treatment plan in the community for 6 months if the hearing officer finds that the person, quote, requires continuing treatment and care under supervised conditions to maintain and improve recovery, and the person is sufficiently stable to benefit from community treatment in an appropriate unlocked setting. Once again, whether someone needs treatment to maintain and improve recovery is a prediction standard, and that makes it unconstitutional. In fact, this standard is so relaxed that it's difficult to imagine who it wouldn't apply to. How often would hearing officers find that people don't need treatment to maintain and improve recovery? Court-ordered community treatment may not sound terribly restrictive, but the reality is that treatment plans can control every aspect of a person's life. A treatment plan can dictate a particular place to live, specify medications to take, limit people the patient can spend time with, impose travel restrictions, and specify particular types of therapy and even the physicians and other mental health professionals a person must see. Although AB 1800 provides that a person must agree to his or her treatment plan, it's fair to say that for many people this would not represent a free choice, but rather a coerced choice, the only means to get out of a mental institution. Calling it a choice is not just demeaning to mental health professionals, it also sabotages the therapeutic value of the treatment plan. As others on this panel will testify, therapy seldom works when it's forced on people. AB 1800 relies on force to ensure compliance with treatment plans. Individuals who don't comply with their treatment plan and who pose an acute risk of physical or psychiatric deterioration may, by court order which cannot be appealed, be rehospitalized for the remaining days of the underlying involuntary treatment certification. Here, again, the bill uses an unconstitutional prediction standard, the risk of deterioration. And it invites inconsistent application because it doesn't specify how much treatment noncompliance warrants rehospitalization. Is skipping 1 day of medications or 1 therapy appointment sufficient? And what happens if a client decides that her medication side effects have grown too severe to tolerate? Does a client who is competent to make medical decisions lose her right to do so as a condition for remaining in the community? Under AB 1800, this outpatient treatment program applies not only to people who've been involuntarily committed, but also to persons, quote, diagnosed with severe and persistent mental illness. The bill provides no definition of severe and persistent mental illness, nor does it specify whether people in this category receive hearings before implementation of the treatment plan, or what happens to them if they later decide to deviate from one or more aspects of their plan. The last aspect of AB 1800 I'd like to mention is its lack of due process protections. For example, there are no due process protections for people facing rehospitalization for not complying with community treatment plans. The bill requires no notice to clients that a treating professional has requested rehospitalization, no hearing to determine whether rehospitalization is necessary, and hence no opportunity to prepare a defense, and no requirement that a court determine if rehospitalization is the least restrictive alternative available. I would be remiss if I ended my testimony without first pointing out some of the very practical problems AB 1800 would create. First, this bill is a very expensive, unfunded mandate, whose burden would fall largely on counties. Many more people would be subject to involuntary hospitalization, and inpatient care is the most costly way to provide mental health services. The bulk of people who are hospitalized would then qualify for outpatient commitment, which would require hearings and the provision of advocates to represent clients. A system for monitoring treatment compliance would have to be funded, as well as a means of rehospitalizing people who don't comply with treatment. The already inadequate supply of community-based mental health services would be redirected to people with court-ordered treatment plans, in effect, displacing voluntary clients with involuntary clients. AB 1800 would make a far greater number of people eligible for involuntary hospitalization at the front end or rehospitalization for treatment noncompliance at the back end, and would mean that police officers would be called upon much more frequently to transport people to mental hospitals. Not only is this expensive, it's also dangerous. Police officers are not adequately trained to respond to mental health crises. Earlier this year, my agency released a report which cited inadequate police training as a contributing factor in the deaths of 2 Californians who were killed by police officers during 5150 procedures. Ironically, this bill would achieve the opposite of what it means to do. As you'll hear from another speaker, the expansion of forced treatment would stop many people who want help from requesting it for fear of losing control over their lives. AB 1800 is not only counterproductive, it's unnecessary. Current law already allows involuntary commitment of people who are dangerous to themselves or others. And it also allows for involuntary community treatment through court-appointed conservators who are given the power to make treatment decisions for people who lack the capacity to do so. In conclusion, AB 1800 will not fix the problems of California's mental health system. In fact, the Russell study, which was commissioned by this legislature in 1986, concluded that the current criteria for involuntary commitment did not force early discharge or create recidivism, and that the way to address these problems was to provide more and better voluntary treatment options. That remains true today. In addition to more voluntary services, we also need discharge planning to ensure continuity of care for clients who are released from psychiatric facilities, affordable housing to ensure safety and stability for mental health clients, and an increased role for clients and their families in the development and delivery of mental health services to ensure that those services provide meaningful assistance to people with psychiatric disabilities. Thank you for giving me this opportunity to testify before you today. I'd be happy to answer any questions you may have.
Thank you very much.
I have a,
Yes, Senator Wright.
I'd like to give you, in fact, the whole panel, if you would give me some thought on whether or not you think any part of the Lanterman Act should be revised or updated. Because I think that's an important issue. I can understand where some of the parents are coming from, but I also think that we have to be very, very careful, because any changes we do make could very, very, very well be detrimental to the person themselves. And I think we have to keep that in consideration, because sometimes I can imagine parents, after years and years, are very, very frustrated and feel that things aren't being done right for their particular child. But in the same instance, I think we always have to keep in mind that individual and giving them the right to lead the best possible life that is available to them. And so I'd like some input if you think there's anything in the Act that should be updated.
Yes, I do, actually, and I agree with what you just said. In fact, I would propose that this legislature consider adding a right to treatment to the LPS Act, because often what happens is that there is no voluntary treatment slots available in the community, and many people are turned away. In fact, as you'll hear from a panel that's upcoming, more than half of people who are seriously mentally ill in this state do not receive treatment that they need because of a lack of services. So I would suggest that a right to treatment would be one way to address this issue. Another thing I'd suggest is discharge planning. Oftentimes people are released from psychiatric institutions with simply a phone number and a couple of days' worth of medication. The phone number doesn't always work, they can't always get a slot, they run out of medication, and they fall through the cracks. In fact, some anecdotal information that we have is that some psychiatric institutions consider discharge to homeless shelters as adequate discharge planning. So I would suggest that that also be added. Another thing I would suggest is that this state consider better promotion of the advancce directive law that has just been updated, just went into effect in its updated version last month, so that clients can dictate through advanced healthcare directives how they want to be treated in the event that they lose capacity. Oftentimes, when people are 5150'd, there is not adequate information about, for example, medications that they have used successfully in the past, medications that have had severe side effects. And people need to be able to retain control over their lives during the period of time that they're incapacitated. And finally, I would say that really the most fundamental thing that's needed here is more money for services, for voluntary services that are client-directed and that provide meaningful help, not just therapy, but also the practical things that people need to survive in the community and live independently, like housing, which is critically needed, particularly affordable and accessible, physically accessible housing, and also employment training, socialization skills, et cetera, the full panoply of things that people need on a very practical basis to survive in the community.
Thank you.
Sure.
Thank you. Who wants to go next?
Good afternoon. I'm Dr. John Nickens, and as Maria Mar indicated, I work in San Francisco for an agency that has contract programs in San Francisco and Napa counties. And I've done this for almost 30 years. There are just a couple of areas I'll mention briefly. And one is there's some research that I think is relevant to the topic, and I can provide you more detailed cites for this in writing.
191, right?
And then I want to mention something about the social rehabilitation model and how we view professional bias as playing into this discussion. But first for the research. 4 distinct areas. One has to do with coercive versus non-coercive approaches to treatment. The Policy Research Associates Incorporated conducted research in 1998 on involuntary outpatient commitment, where they used a comparison group. What you'll find if you read or your staff reads through some of the research is that much of it is done without comparison groups. Okay, this is one that used comparison groups. And what they found was that it was nearly impossible to effectively implement court-ordered outpatient treatment, and that it had no added value in improving treatment compliance. Specifically, and they looked at both court-ordered and voluntary clients and then after treatment. Specifically, they found there were no differences in arrest or violent acts committed. There was no additional improvement in client compliance with treatment. There was no additional increase in continuation of treatment. There was no difference in rates of hospitalization, and there was no difference in lengths of hospital stay. What was really important in the study is that both groups were provided intensive services that they had not been offered before, and that both groups made comparable improvements. Their conclusion, of course, was that it was the availability of services and not the coercion that made the difference. A very important study. We believe that the cost of implementing, enforcing, and managing the outpatient commitment program would be more effectively used in providing additional services that are accessible to people. Regarding client competence in decision-making, the MacArthur Treatment Competence Study, 1998, identified and addressed the 4 legally relevant variables. Because there's a lot of things you can talk about, but they really distilled it down to the 4 that they felt were really relevant. Ability to state a choice, ability to understand relevant information, ability to appreciate the nature of one's own situation, and ability to reason with information. They included 3 distinct groups in their study. Again, something that's not done in all the studies. They included persons recently hospitalized with mental illness, including schizophrenia and major depression. The second group was people hospitalized with physical illness, and the third was people recruited from the local community where persons were discharged to. The results showed that while persons with mental illness more often showed deficits in decision-making performance, the majority of people performed adequately. Now, the reason why that's important is because it obviously speaks to any sort of blanket application of restricting people's rights to make choices.